Welcome to the third installment of the Women's Health series by SAAPRI. Today, we're going to be talking about menopause and sexual health in South Asians, as well as discussing pelvic floor health. My name is Prottusha. I am the Health Equity Research Fellow at SAAPRI, and I'll be moderating this event. And our two wonderful speakers who have joined us will introduce themselves shortly. But before we get into that, just wanted to tell you a little bit about who SAAPRI is. So SAAPRI stands for the South Asian American Policy and Research Institute, and we're a nonprofit, nonpartisan action research organization. We were established in 2001 with the mission to create data-driven and human-centered research to strengthen community for South Asian American communities. Using our research, ultimately, we aim to advance public policy by proposing data-driven objectives. And SAAPRI is also part of this greater coalition called the Asian Health Coalition, which is a network of organizations that are committed to advancing health equity. We help promote the All of Us research program as part of our role in the AHC Coalition, which helps gather important clinical data from South Asian Americans to better inform personalized care. If you're curious, you can learn more about the All of Us or the AHC through these links. And feel free to kind of ask questions about it in the chat too, and we can drop the links there as well. And before we get started, just a disclaimer, the information provided this event is for general informational and educational purposes only. We don't provide medical advice, diagnosis, or treatment. And any views expressed by speakers, panelists, or participants are their own and do not necessarily reflect the views of SAAPRI. If you have medical questions, always feel free to kind of ask your healthcare provider, and they can best help you with those questions. Alrighty, so now moving on to our panelists, I wanted to give both of our panelists just a minute to introduce themselves and their experience with this topic, and we can start with Dr. Rahman on the left.
Hi, everyone. I'm very excited and honored to be here tonight to educate a little bit about this taboo topic of menopause and anything around sexual health. I am a board certified gynecologist with a specialty in sexual medicine and menopause management. I have my own practice in downtown Chicago, and I've been focused on these areas for the last 10 plus years. I'm also a clinical assistant professor of OBGYN at Northwestern. And so I do some teaching over there. I'm part of the International Society for the Study of Women's Sexual Health, and I'm on the board in the scientific chair this year, and also part of the Menopause Society, as well as the International Society for the Study of Vulvovaginal Diseases. So this area is a passion project of mine, particularly with regard to, South Asian women. I, am actually... just a plug, I am going to be publishing a book in the next 6 months on South Asian women and sexual health. So that's something I don't think it's really important, but it's not out there yet. So, but thank you for having me.
Thank you. And Shital, if you wanted to go and introduce yourself as well.
Yeah. Thanks, Prottusha. I am Shital. I'm a doctor in physical therapy. I have been practicing physical therapy for about 17 years now. I was born and raised in India, and that's where I completed my bachelor's in physical therapy, graduated in 2006. I've been in US since 2007, so most of my work experience and life has been in US since then. I have worked in various multiple settings, from skilled nursing, assisted living, independent living facilities, home health care, ortho, outpatient. I found my passion in ortho outpatient, particularly specializing in pelvic health. I completed my doctorate in physical therapy in 2019. And since then, I have been diving deep into the pelvic health world. All things related to pelvic health, mainly focused on women's pelvic health. I'm currently working at Athletico, and I am a clinic manager at Lincoln Park Sono Clinic for Athletico. And I'm also the regional coordinator for the pelvic health program, overseeing the region of Illinois, some parts of Wisconsin and Indiana. I when I'm not doing my pelvic health world and when I'm not with my patients, I enjoy spending time with my family, living with my partner in Chicago and our two boys, and love playing board games, watching movies with them, painting, dancing, and doing yoga.
Awesome. Great to hear. Great to hear how passionate both of you are about, women's health, pelvic health, and sexual health. I briefly talked about myself earlier, but I'm a fourth year medical student. I'm an MD MBA student at Northwestern. I'll be graduating this year. And I'm also the Health Equity Fellow at SAAPRI. I have been for the past, I guess it's my second year now. Very passionate about women's health and gynecology and all those things. So really excited to start the conversation today. So before we get started talking about topics, we wanted to take a very quick poll from the attendees just to get a sense of where people were at in their knowledge of this topic. So the link to the poll will be sent out in the chat by one of our moderators. I think Anushka is sending it. So it should show up as a Zoom poll. And if all of you could just quickly answer just 3 questions, we'll give everyone like a minute or two. And then we'll kind of go over the results and get started. I'll give everyone just one more minute and then we can go over them. Okay. All right, I'm going to end the poll now and the results should show up. Let me share that. Can everyone see the results of the poll? I can't tell. All right, I'm just going to read them out to you. So to our first question, have you heard of menopause before? Everyone does seem to have heard of menopause, which is not surprising considering this is a webinar on it, but everyone, says that they know what menopause is. And then it sounds like a lot of people either know someone who's gone through menopause or is going through it themselves. And then, something that we'll talk about today is this negative stigma that menopause has in our South Asian community. And a lot of the respondents are also agreeing with that menopause does seem to have this negative stigma. So thank you for answering our questions. And we're going to get into our first topic of the night, which is just defining what menopause is. So Dr. Rahman, I just wanted to call on you to, define what menopause is, what's the average age of onset, and then we can talk a little bit about the changes and these 3 different phases that are listed in the second bullet point.
Sure. Menopause by definition is a retrospective diagnosis. So it's 12 months without your menstruation in this time of life. And so, usually women in their mid to late 40s, when they start having these periods of time without normal cycles where they're skipping cycles, they often come in and they're saying that, oh, I think I'm on the countdown now for the 12 months. But then if they have a cycle, then it resets. So it's a retrospective diagnosis. It's basically one defined final menstrual period, right? So that final day And then everything after that is postmenopause, or you are menopausal. Perimenopause is by definition around menopause. And it is the period of time leading up to your final menstrual period. And what it means is it's a clinically significant period of time, much more so than, even just the period of time after menopause, because the hormonal fluctuations are incredibly difficult. And it's really chaotic, where some months the estrogen levels are super high and you have symptoms of high estrogen, and other months you have super low estrogen. And so it's the delta from high to low that makes women really really struggle during this period of time. And so it can be, for some patients, months, and for other patients, 7 to 10 years. So, and we don't really have a good way of predicting it other than looking at, maternal history and some other factors. And it's really, like I said, perimenopause is a clinical diagnosis. So what that means is no blood work will definitively diagnose it for us. Sometimes we get blood work when people like have an IUD and they're not menstruating, or maybe they've had an ablation and they don't menstruate, or they had a hysterectomy, but they have had their ovaries retained. Sometimes we'll get blood work, serial blood work in those cases to help us get a better idea. But the reality is, if you think about the fact that we have estrogen receptors from head to toe, every cell in our body has estrogen. So when an estrogen modulates so many functions, that when we start having this differential, this huge delta of estrogen affecting each cell, each tissue can respond differently. And so for some people, it's cognitive stuff, right? The cognitive distress that comes with perimenopause is, anything from the brain fog, like, hey, why did I come in this room? Wait, I'm burning the bagels now. Like, what's happening? To really mood dysfunction, which is probably one of the biggest ones. And I'm going to talk to you guys about a study that was done on South Asian women at some point. But that is, one of the biggest feelings of like just not feeling like yourself is a very big feeling in perimenopausal women. And it's such that, there's anger outbursts, there's, depressive symptoms, there's anxiety. All of a sudden I can't fly, I can't go on, roller coasters like I used to. Women say these things, and it's all related to the fact that estrogen modulates so many of your neurotransmitters in your brain, and therefore modulates a lot of your mood symptoms. And so that is another issue. Think about your muscles, the muscle aches, the muscle fatigue that people have, joint pain, frozen shoulder. We now have a definition for this called the musculoskeletal syndrome of menopause, again, related to the changes in estrogen. People sometimes develop frozen shoulder. They might have joint pain. They might have, patients who are athletes who, say they don't recover as well anymore, all related to this varying periods of time with high and low estrogen. And then, of course, you think about your genital urinary symptoms, and that can include, urinary frequency, urinary urgency, vaginal dryness, vaginal irritation, sexual pain, and some of those concerns. And then the things that people think about the most when they think of menopause, which is your vasomotor symptoms, your hot flashes, your night sweats. And these are symptoms that I feel like are really closely associated with menopause. So people think, oh, it's just a hot flash. Oh, it's because, at the base of our brain, we have a thermoregulatory center that needs estrogen to modulate it. And when you don't have that, or when that estrogen changes, people can get a sense of heat intolerance. They can actually get waves of heat and get flushes of heat. And they can just feel very uncomfortable. So it's a variety of symptoms. We can talk about each and every one of them, but the perimenopausal period is a period of real distress for people.
Yeah. What do you, in your experience, what would you say is the most common symptom that patients come to you with?
There's quite a number of them. I mean, you would think it was hot flashes or night sweats. I feel like the biggest symptom that I hear all the time is that I don't feel like myself anymore. And that means that my mood is like, people are very angry. They're irritable. I always joke like maybe the Karens of the world are just, postmenopausal or perimenopausal, not getting their estrogen, because the reality is like, this irritability thing is very big. Anger is very big. I think depression symptoms are huge. New onset anxiety. There's a 4-fold increase in antidepressants in midlife women. because they're more likely to get an antidepressant than they are to get hormone therapy. And so I think that's a big symptom. Of course, you always think, more than 85% of women will experience a hot flash or thermal dysregulation is like what I like to call it, where maybe like you have the temperature at 60 degrees and everyone in your family is wearing a sweatshirt except you. I mean, that's a very common thing people tell me. And then some of the genital urinary symptoms that I talked about, that painful sex, that difficulty with urinary function, pelvic floor dysfunction, which Shital will talk about as well. But I think some of those symptoms are most profound. But I really, really think that that's a very common reason that people see me, is just like, I feel like I'm going crazy. I feel like, and you have to think about what a midlife woman experiences, right? Like, you're experiencing this huge roller coaster of hormones. But on top of that, you have the weight of the world on your shoulders. You might have aging parents that you're taking care of. And here in the South Asian community, we take that very seriously, right? We're not putting our parents in nursing homes unless it's an all South Asian nursing home, and maybe they consider it, but like the majority of the time we don't do that. We take care of our parents. They live with us. Then you have maybe kids that are like teenagers or coming to, I always say, like, my household, there's perimenopause and puberty happening at the same time, and it can create a real, excuse me, shit show of activities. But like, the reality is, like, you have that. And then some women are, pivoting because, they're experiencing divorce. Can you go find out why this dog is barking so much? Sorry. Some are pivoting because, people are experiencing divorces. Some people have had to deal with death. Some people are at the pinnacle of their careers, right? Imagine a CEO or somebody giving a TED talk or, something, and they're on stage and they get brain fog. Do you know how endangering that is for not only like their career, but like self-esteem and their worth? Like, it's much more than just a hot flash or just feeling some of those symptoms. And I think that, we have to take this period of time very seriously. And there's no reason, menopause is inevitable. It is a gift to be able to go through menopause. That means that you've lived long enough to do it. But we live a third of our life in this estrogen deprived state. So we should really not suffer through it.
Yeah.
And that's the truth of the matter.
Yeah. And yeah, thanks for mentioning, I think, the specifics of like South Asian women who are going through it and all the family responsibilities and often career responsibilities that you have to manage while also managing this condition.
Yeah.
For the study that you mentioned, I'd actually love to hear about it, because our next, topic is, and this is open to both you and Shital, is, how does the South Asian community think about menopause? When you think about your own life, people or patients that you've seen, and this is open to both of you, whoever wants to answer.
Okay. Well, I'll start because there was a study that was just published in the Climacteric like 5 days ago, and it was a retrospective study. It was actually a study that surveyed. Do you guys know the Masala study, the mediators of atherosclerotic South Asian? It's basically the one about the big heart study that was done on South Asian the community. And just to reiterate, we make up about 25% of the world population, but we make 67% of the world heart disease, and we're number one in diabetes. Hold on one second. Sorry. But we make up, 67% of the world heart disease. Heart disease is still the number one killer in women. Diabetes, South Asians are number one in diabetes. So we have all these cardiometabolic risk factors that increase in postmenopause, right? A woman is more likely to die of a heart attack at her first heart attack than, a South Asian woman is more likely to die in her first heart attack than any other race, actually. And so, we have all of these, abundant risk factors. We know that menopause is changing them. And so what that means, the study showed, is they looked at, in the study, the average age was 59 for most women. So it was most women that were past menopause. They looked at retrospectively what they thought the age of menopause was. And so most people said it was around 48 years old. Most studies have showed that South Asian women do go through menopause earlier. So their final menstrual is on average, between 47 and 48, depending on which study you read. So if average Caucasian woman goes through menopause at 51 and a half, almost 52, you're talking about, 5 extra years of estrogen that you're not getting, right? Because we know, and then this study also showed that these women a third of them went through premature menopause, and premature menopause means age less than 45. So then again, you have this abundant risk factor of estrogen deprivation happening. And so I think that's very important. Oh, sorry. That's very important to remember because, again, visceral fat accumulation in the midsection happens to women in menopause. There is also an increase in polycystic, South Asian women have more polycystic ovarian syndrome, right? At least 25% of South Asian women have polycystic ovarian syndrome, which is another cardiometabolic risk factor. And so we're dealing with all these things that actually can affect our longevity. And so that's why when I talk about hot flashes, what we know, it's a harbinger for something else going on. It's not a benign condition. If you have uncontrolled hot flashes, we know that you have higher rates of diabetes, heart disease, obesity, and premature and actually premature death. So that's why I say it's not just a hot flash. You have to treat these hot flashes for your cardiometabolic health. So that's something important to remember about the South Asian community. The other thing they saw in this study was that at least close to 15 to 18% of women had signs of depression. And so I think that's very important to remember, that the mood dysfunction, and 9% of women complained about anger and excessive anger. This anger that causes disruptions in their relationships, So I think it's very important to remember how those things affect their relationships. And then close to a third of women had urinary incontinence symptoms. So these are specific to the South Asian women, right? That we're having this depression, anxiety, anger. And then another study had also showed musculoskeletal symptoms were predominant. So you think about all these symptoms that, we're having menopause earlier. We have risk factors that put us at risk for dying sooner. And so we have to be on top of our health in midlife. And how do South Asian women look at menopause? I mean, we can have a discussion about this. Some studies show that it's looked at very positively, right? Because if there's a lot of taboo around menstruation, when you stop menstruating, you don't have to think about it. You don't have to think about if you're having a period before you go to a mosque or a temple, right? A lot of people have a taboo around menstruation when you go to a religious place. And so, there's that aspect that some people find it very freeing. All of a sudden, I can pray whenever I want. I don't have to worry about my menses. I'm done with considering childbearing. Some people say like they're done with having sex. And so some people find that freeing, Other people find it such that like they want to have those relationships with their husbands. But, the majority of men also have cardiovascular disease. And we know that, things like, orgasm function and arousal and erectile dysfunction all show up first, because these vessels that are in our genitalia actually are first sign of something happening, right? So when people develop sexual dysfunction, that's why sexual dysfunction is another harbinger for other issues that you're experiencing. So we have a lot of layers here to think about, the layers. And then there's a general, as much as the SE people love it when their kids go into medicine, I have to say through my own experience, they're the least likely to want to take medications. It's really interesting. They don't want to listen to doctors, but they want everyone to doctor. It's very interesting. And I think it depends on, where, if you're a recent immigrant or if you're in the, some people have a lot of respect and deference to the medical community and other people have distrust. There is this issue of whether or not you're able to even bring up the topic, especially the sexual health concerns, right? 40% of women have libido concerns. Have up to 85% urinary syndrome and menopause by the sixth year of postmenopause. So what does that mean? That means they have urinary frequency, urgency. They feel like they're having frequent UTIs. They're having sexual pain. They might be having, vaginal irritation and dryness. And these are quality of life issues. But there are also, in some ways, life and death issues, because what we know is that if you're over the age of 65, you're likely to get 30% of women will get at least one UTI. And closer to 85, you have more than one UTI. You can get up to 3 UTIs a year. So these patients end up with something like 20% of them that might eventually end up in the hospital because of a UTI that leads to a hospitalization, like sepsis, or when you get bacteria in the blood, and then that leads to a significant infection. And 6% of women die from UTIs, right? This is not a benign condition either, especially in elderly population. And so things like vaginal estrogen that prevent UTIs are really important for treatment, actually.
Yeah, yeah, thank you for sharing all of that data. That's and all the complex considerations that really go into how South Asians think about menopause. I wanted to open the floor for Shital and ask, um, well, how do you think the South Asian community thinks about it? Like, do you have any responses to anything that Dr. Rahman said?
Thanks. I think Dr. Rahman summed it up very beautifully. And one thing I agree with everything that she says. And although I have not read so much research pertaining to the South Asian population per se, I have done some anecdotal observation. And the pattern that I notice is yes, some of the women will find it very freeing that, oh, I don't have to worry about sexual encounters anymore. But then there are some women who will think, who they kind of feel like this is an end of an era of sorts, like their life is changed in a way where they don't have to worry about things, or where they have to, there's certain sort of resignation from living life fully. That's what I observe. And the things like low energy levels, pain in the body, or the weight gain, it's accepted as a normal, which I think is such a false normal. There is so much lack of awareness, and they are not aware that these things can be changed. There is so much help out there, medically, and in other ways, that these things don't have to be their new normal. So that's what my observation has been.
I'm glad you brought that up too, Sheetal, because I think that there is a difference in how, the South Asian community views aging to versus like a really Western, like in Western society, I think aging is viewed in a capacity of like, there's I think a lot more ageism, right? Like in terms of how we look, it's a very youth-centered society. And, if we look at our communities, at least, like some of the women, the older women are the matriarchs of the household. And so, there's a lot of deference given to them. They have a lot of respect. And so I think for some women, they want to reach that level, right? They want to reach that level where they have the power in the house, or whatever the case may be. But I do think there's then some mixed feelings about, oh, I don't have reproductive capacity anymore. And if your identity is wrapped up in reproduction, then those are the patients that I see, and the communities that I see that really get a negative feeling around it as well. And then, we're all kind of acculturated, here. I think that like we pick up on some of the ageism too, and we feel like, obviously menopause we have a whole menopause revolution happening. Oprah Winfrey just did a big special on it in prime time. And so I think that the narrative around menopause has certainly changed, as the Generation X and as millennials are starting to experience these symptoms. But I do think that, we have still a lot of chipping away to do, because just as another note, like, there are a lot of mental health concerns that come up in menopause, and mental health is highly stigmatized in our community just as much as sexual health, right? So as much as you don't want to talk about the painful sex that you're having, or, the urinary symptoms or whatever, you also don't want to talk about the depression and anxiety because it's not real, right? Like it's like we're supposed to just suck it up and deal with it because no one believes in therapy. And like, I mean, I can even tell, like, when I talk to my dad about therapy, he's like, what? That's silly. It's just like that traditional belief that like you don't need it because it's not real. And so I feel like that's another sort of obstacle that we have in the South Asian community around the stigmas around not only sexual health but mental health. And those are the two biggest things that sometimes women experience, right? So
Yeah. Yeah, those are definitely, huge changes in people's lives and can have really, really like big downstream effects. I want to kind of extend this topic. We talked about like changes in sexual health and changes in, maybe your ability to have intercourse or have the kind of sex life that you want. And I want to spend a little bit of time talking about the pelvic floor because it's also a topic that, we don't really talk about. And I wanted to invite Sheetal to really share her expertise on, what is the pelvic floor? Why is it important? Why should we care about it? And then we can talk a little bit about how it's impacted by menopause and, what you do as a pelvic floor physical therapist.
Wonderful. Thank you so much, Prottusha. Um, thanks for asking that question too, because it's so important. A lot of us, we really don't know what pelvic floor is and how important it is. It's actually a miracle area. It does so much without us knowing, and it has so much capacity of us to do with the knowledge. It's amazing. So I have this amazing model in front of me over here. I hope you guys can see it. So this is our human pelvis, and the two pelvic bones joined together in the front over here, called the pubis, and in the back over here, that's your spine, and that's your tailbone right here. So the pelvic floor is nothing but a bundle of muscles and fascia, which is connected in the front to the pubis and in the back over here to your tailbone, right there. So think of a hammock. So two coconut trees, one coconut tree would be your pubis, the other one would be your tailbone, and this hammock in between is your pelvic floor muscles. These pelvic floor muscles, there are three layers of these muscles, and these muscles have to have a certain tone. So think of a trampoline. When we bounce on a trampoline, it has to have a very happy tone. We can bounce on it, it has some give to it. The pelvic floor muscles have to just be like that. If they are too rigid, too tight, that's not going to be good. It might cause some dysfunctions. And if they are too loose, too giving, that's not good either. It might cause other end of the spectrum of dysfunctions. So that's what the pelvic floor is. Why is it important? It has five main functions. So the first one is it houses three main systems in our body. The first one is our bladder. So that's our bladder, and it sits right here behind our pubis. And then in the female pelvis, it would be our uterus and our vagina, which sits right behind it. And then is our rectum and the anal canal, which sits right behind it over here. So you see how close together they are, and that's how they are in real life too. And what goes on in one system is going to go on in the other, is going to affect the other two systems as well. So the first function is supporting these three main systems. The second one is the first two layers of the pelvic floor muscles, they act as the gatekeeper. They act as the gatekeeper for our bowel and bladder. So they will stop the flow of the urine. They will also allow the flow of the urine out of our body. They will stop the evacuation of the bowel movements. They will also control the emptying of the bowels. The third function would be sexual function. So the first two layers of pelvic floor muscles, right there, they are all responsible for orgasm. Fourth one, these muscles are responsible for stabilizing the pelvis and the spine. And the fifth one, which we call as the sump pump function, which is more like allowing the circulation of some of the blood vessels to happen really well from between the upper body and the lower body, because the pelvis connects the upper body to the lower body. So there has to be certain amount of circulation going in between, and these muscles, they contract, relax, so that that circulation can happen effectively. The pelvic floor muscles, they work in synergy. They have to work in tandem with our respiration. So breathing is so super important for a good pelvic floor function. If you think of the pelvic diaphragm right here in the bottom, it is the bottom of a canister, and the top of the canister would be our respiratory diaphragm. So we breathe, say, about 17,000 to 22,000 times a day. And each time we breathe, there is some movement of the organs happening in our abdominal region. The pelvic floor muscles have to be so giving and in a happy tone that these motions can happen in a nice, relaxed manner. And if that doesn't happen, there is sort of a pressure mismanagement that goes on in our abdominal region, which can cause some dysfunctions. And we will cover those dysfunctions in a bit later time. How are these muscles impacted by menopause? Just like a while ago, Dr. Rahman explained us how we have estrogen receptors all the way from our head to toe. Pelvic floor muscles have a lot of estrogen receptors. And when we have these hormonal fluctuations going on, when the estrogen is dipping down, these muscles are not happy. It's going to affect the resilience of the muscle. It's going to affect the tone of the muscle. You will notice the muscles start thinning out. The tissues around the vulvar tissues in your pelvic region will start to thin out. You may get irritation of the tissues. Um, there is more rigidity, there is more dryness of the tissues. In general, those tissues are not happy. And that's how menopause can affect the pelvic floor muscles. All of these things that we just described can be very easily termed under the term that Dr. Rahman earlier used, called as the genitourinary syndrome of menopause, wherein women may experience repeated UTIs, they may experience difficulty urinating, or they may experience incontinence. They may also experience lack of control, or maybe the urgency. The urgency is so quick. Like if you want to go to the bathroom, you get the urge, you feel like, oh, I have to go. And then if you don't go right away, you may have a leak. So that's the urgency. You may have increased frequency where you feel like, I just went to the bathroom and half an hour ago, and now I need to go again. So that urge is there when you sit on the commode, you try to evacuate, you may have just a little trickle come out. So that may increase. Some women may also have constipation issues. Some women may have lack of control in that area. It's very common for menopausal women to feel like, I don't have any support down there. I feel like something heavy, or sometimes they will describe like, I feel like I'm sitting on a golf ball, or something is right there which doesn't feel normal. It doesn't feel like before. So all those things will encompass, either musculoskeletal syndrome of menopause or genitourinary syndrome of menopause. Coming to the next question, which is, what is pelvic floor PT? So if any of you have had experience going to a physical therapist where you have either had a surgery of, after a fracture, or if you have had pain in any of the joint, the way you get rehabbed is you get some manual therapy on it, you get some exercises, you get um, some activities to do differently. Pelvic floor physical therapy is very similar, but it is more pertaining to the pelvic region. However, when we are doing pelvic floor PT, it is never just localized to this cave. It encompasses so many things, wherein we are going to check the mobility of your spine. We are going to check the strength of your hips and the mobility of your hips. We are going to see how your breathing pattern is. We are going to see how you're moving in general. It also encompasses intravaginal assessment and colorectal assessment. So it's very similar to a gynecological examination, but a little bit differently. With the intravaginal assessment, we are going to definitely maintain the universal precautions and assess the tone of your muscle, how your muscle is contracting, how your muscle is relaxing, whether your muscle is able to relax or not. Do you have any tenderness when you are touching these different spots and muscles? Um, and then that is all in terms of intravaginal assessment. Some women may warrant examination of the colorectal assessment, and that entails the same thing. So once we collect all this information, we develop a plan of care in terms of, okay, what is not functioning well? Are your muscles sitting in a very heightened tone? Like when we talked about the trampoline, is the trampoline rigid? Or are your muscles sitting in the other end of the spectrum, which is very super loose? There is no control at all. There is no contraction happening. It's just sitting there dormant, doing nothing. That's what we are going to check. And depending on the findings, The plan of care is developed where we do different exercises, which entails about mobility of the spine, strength of the hips, breathing exercises, lot of breathing exercises. When we are treating pelvic floor muscles, breathing goes hand in hand with any and every exercises that we are going to do. And a lot of education. Pelvic floor PT incorporates a lot of education and awareness of our body. Um, I am so amazed when some women come in the clinic and they do not even know what their vulva is. They don't even know what they look down there. And sometimes there is shame and guilt associated with it. Sometimes there is embarrassment associated with it. So a lot of just teaching on this is your body part and understanding how it functions, how it looks. It's okay to touch it. It's okay to treat it by yourself. We do a lot of education on self treatments. So that entails a huge part of pelvic floor PT as well. And typically, a woman who has incontinence symptoms, pelvic pain symptom, will see us for anything between 6 weeks to 12 weeks. We do a lot of collaboration. Like I would, if Dr. Rahman would send a patient to me, we'll do a lot of collaboration in talking to the doctors, in talking to the sex therapist, in talking to the psychologist. And it's more like an interdisciplinary approach when we are treating the pelvic floor and to treat a person as a whole and not just one single body part.
Yeah. Yeah, I want to kind of transition that into talking a little bit about, do's and don'ts for the pelvic floor, maybe spending a couple minutes. Just these are some, I think, pointers that I wanted to focus on, and maybe talking specifically about, like South Asians and their diet and lifestyle, or maybe their exercise, and what you advise your patients on.
Perfect. Yes, so I'm going to say do's and don'ts simultaneously. One of the major do's that I would say is empty your bladder every 4 hours, 4 to 5 hours. Try not to empty it sooner than that. If you feel like you have the urge or you want to keep emptying your bladder sooner than that, that's a sign that you might need to see a medical practitioner. Second, when emptying our bladder, we want to sit fully relaxed on the commode. A lot of us women, especially when we are traveling, and I was guilty of that once upon a time, we hover upon the commode just because we think, oh my God, the toilet seat is so dirty. And we want to hover on there to empty our bladder. And that's a big no in terms of good pelvic health. We want to sit down on the commode fully, and the reason being, when we are sitting on the commode, these muscles, they will just relax naturally. Emptying the bladder and emptying the bowels, these are relaxation activities, which means the pelvic floor muscles have to relax and lengthen fully in order for that evacuation to happen in a rightful manner. So when you're hovering upon a commode, you are actually doing your pelvic floor a huge disservice. You are like just trying to force something out there, which is not how your pelvic floor muscles are programmed. So you are setting yourself up for a dysfunction eventually. So do not hover on the toilet seat, sit down. And I understand the hygiene aspect of it. Just put the toilet paper over there, or carry, if you're traveling, there is travel toilet seat covers. And I would like to mention there was one research which was done where they found out what were the most unhygienic surfaces that were touched. And door handles, believe it or not, have the most germs that we can think of. So toilet seat is not as dirty as you think. It's door handles which are more dirty. So do yourself a favor, have a seat on that commode and evacuate fully in a relaxed manner. Second, when it comes to the bowel health, we want to have a very balanced, healthy, nutritional diet. Our South Asian community, our diet is very heavy on carbs, which is not a bad thing, but we want to balance it with having some good fiber in as well, and a moderate amount of protein. So having a good balanced diet is going to have a very healthy bowel, and it's easy to pass that. And talking about passing, when you are passing your bowels, you again want to sit very comfortably on the toilet commode. And if you have heard something about squatty potty, then please invest in that. The reason being, when you are sitting on a squatty potty, your feet are high up. So basically, your hips are lower than your knees. And when that is the position, what happens is your rectum over here, there is this muscle right here, which sits like, as if reining a horse. And when that muscle is super tight, that is a signal to your rectum like, don't evacuate, we are not ready. However, when that muscle relaxes, the angle between your rectum and the colon over here changes. So when that angle becomes straight, it's so easy to pass all that bowels. So we want to sit in a position, and hence deep squat. Like, I love deep squat pose. Like, you can have an amazing evacuation with a deep squat pose. So try that, or just do the squatty potty. It's going to work wonders. And one other thing is, you do not want to hold your breath when you're passing your bowels. So when you are in the process of evacuating, a lot of us like trying to push and strain, and we hold our breath, which actually doesn't serve for our pelvic floor. It can set you up for a prolapse in the future or just some other dysfunctions. So as you're passing your bowel movements, you want to have a nice, gentle breathe out through your mouth, which will allow you to manage the pressure in your abdominal region much better and have that bowels pass in a much efficient manner. Believe it or not, you will feel like, oh my gosh, I've never had a better poop than this. So try these things out. Don't rush when you're peeing or pooping. That's a big one. Let it evacuate fully. It's a very relaxation process. Um, when it comes to the sexual health, it's always a good idea to pee after having a sexual intercourse. Um, Water intake, there is no real research that says that, oh, this is the right amount of water, but it's very well agreed upon the pelvic health community that 48 to 64 ounces of water a day is a good number, or you can drink about half your body weight in ounces. And some of the drinks like caffeine, coffee, tea, those are bladder irritants. So you don't want to drink that after a certain time of the day. Every body is different and will respond differently, but you can definitely stop right somewhere around 3 or 4 o'clock. You don't want to drink too much water at the end of the day, especially you are waking up if you are waking up in the middle of the night to go pee. The normal for the nighttime voiding is 0 to 1 time. So if you are waking up once, that's okay. But you don't want to, if you're waking up more than once, there is something going on, you want to see your doctor. And the other thing is, what was I going to say? 0 to 1 time of voiding at the nighttime, and it'll come to me later. I just had it, but I guess I will end at that.
Yeah, those are really good kind of pieces of wisdom to keep in mind for pelvic floor do's and don'ts. I myself am also guilty of
Yes,
rushing to go to
yeah.
the bathroom, when you have things to do and you're like, I gotta go get back to work.
Yeah. The other thing I would reiterate that I see in my office all the time when we have a lot of patients who have high tone pelvis and hypertonic pelvic floor leading to sexual pain and sexual dysfunction. Obviously, vaginismus and a hypertonic floor in the South Asian community is pretty significant. But when you talk about people, and sometimes I'll ask patients who have, a history of anxiety, have you ever noticed that you're clenching your jaw? And 9 times out of 10, actually 10 times out of 10, if they're clenching their jaw, they're clenching their pelvis. And so if you're constantly, Shital will tell you, if you're constantly clenching your pelvis, you're going to get those shortened muscles. There's going to get less blood supply, less oxygenation. And then you get this high tone pelvis that gets weak, actually, not strong. And actually, with all that lack of oxygenation and really like increased lactic acid buildup, you get a lot of burning at the opening. And so that's a big source of sexual pain for patients, is the fact that, outside of the hormones, we know that with the hormones, with the lack of estrogen and the 50% decline in testosterone, your genitalia needs both. And so without it, you have that shrinkage of the vagina, you have shrinkage of the labia, you might have shrinkage of the clitoris. And then on top of that, the muscles that are not getting enough blood supply because of the lack of oxygen, of the lack of blood flow related to hormone deficiency, and then on top of that, you're clenching. So you have like a double problem here, where people are clenching and then causing themselves to get a more of a high tone pelvis.
Correct. And then I just remembered what I was going to say earlier. Avoid just in case voids. So you're allowed 1 to 2 a day. Like say I'm going out shopping and I'm not sure like what's going to be. I'm going to be out there for 6-7 hours. All right, I will do just in case voiding at home and then leave the house. However, you don't want to do it like 3-4 times a day, and because that's you're setting your bladder up for like dysfunctions in the future where the bladder can act as a toddler. It's a muscle. It can hold up to 500 milliliters of fluid. And it's this muscle where it can stretch all the way up. So you want to allow it to have that sort of capacity and fill that much fluid before you get the urge, so that you are using those impulses that go to the spinal cord through to the brain and then back to the bladder, and then you want to evacuate fully. If you try to go too often, you're just setting yourself up for failure in the future, something which we call as the urge incontinence, which can also manifest later on or even before that. So that's one thing that I would like to tell you, that try not to go too often. And then also don't hold when you have the urge to go to poop. Respect the poop. You got to go when you got to go.
That leads really nicely into kind of talking about pelvic floor dysfunctions and things that you do see in your patients who have pelvic floor dysfunction. And specifically, I'm curious to hear, are there any patterns that you see in your South Asian patients? Dr. Rahman mentioned like hypertonic pelvic floor, and that pattern is with regards to patterns of disease or patterns of like, this is the way South Asians tend to react when I tell them something, or and obviously that second question, like what are things that we can do to help each other when it comes to this problem?
Okay. Most of the dysfunctions, like we have covered in bits and pieces, and Dr. Rahman has already mentioned it, but I'm going to just go ahead and say the names of it, like urinary incontinence, a big one. And other one is constipation, pain with sexual intercourse, feeling of heaviness in the vaginal region or in the rectum. Sometimes it's hard to control flatulence. So some women will say, oh my gosh, I just cannot control. Like I feel like I'm just passing gas uncontrollably. Some women may also have incontinence of the fecal matter along with the flatulence incontinence. Urgency to urinate, cannot wait, have to go to the bathroom, feel the urge, have to rush to the bathroom. And believe it or not, a lot of falls happen while going on the way to the bathroom. So that's a huge, cause of hip fracture and sometimes even death in elderly women when they have incontinence symptoms. Um, Increased frequency to urinate. And sometimes women might feel like, I never felt like something was popping out of my vagina, but now I feel like there is some tissues hanging out there. So that might be a sign of prolapse, and that's why you want to see a doctor right away. If ever you feel like you are straining too much or pushing too much to have a bowel movement or urinate, that's when you want to see, that's a dysfunction. You want to see the doctor. And also, if you feel like, man, I always feel like I'm not emptying my bowel completely, I always feel like that something is still sitting in there, that's a dysfunction. One other thing I would like to reiterate, like no amount of pain when having sexual intercourse is normal. And that is one misconception that I notice is very prevalent all across the board, whether it's South Asian or some other, but more so in South Asian, where they are like, yeah, it hurts a little bit, but so what? Like, that's what a lot of women may have that pain. So no amount of pain with sexual intercourse is normal. You want to see a doctor whenever you have that kind of symptoms going on. The other one major that I see is repeated UTIs, which Dr. Rahman had already said is something which is very common as a part of the dysfunction.
And yeah, I'm just going to reiterate the thing about sexual pain because it is high prevalence in our community. We did a retrospective survey and study on this that found anywhere from 40 to almost 60% of South Asian women experience sexual pain, or in some literature searches they'll call it vaginismus. Vaginismus is a historic term that really refers to involuntary contraction of the pelvic floor when attempt at penetration. It's now considered in the genital pelvic pain disorders, as an umbrella term, but it really means you're just involuntarily contracting. And so it leads to a lot of unconsummated marriages and relationships. And this is something I treat pretty frequently in my office among South Asians, along with pelvic floor PT. Sometimes we have to use vaginal Botox and other things that get really aggressive because it causes a great deal of distress. And the longer time that people end up waiting, I mean, I've had patients 7-8 years into a marriage, and they're finally like, okay, I think we're going to have a kid now, but like we can't, we've never actually consummated our marriage. We have oral sex, we have other types, we have other types of ways of pleasuring each other, but they can't have penetrative intercourse. And so I think that, that is a big problem in our community, which is like the reason I'm writing this book. But it is one of the things that I see, and it's a constellation of, it's a combination of probably the stigmas associated with discussing, sex, really around the shame and, the concepts of virginity and chastity and preservation of all of that, that lead to some of these issues. And then the lack of discussion, right? Like 60% of people don't want to talk to their partners about it. Most of the time they're not bringing it up to their healthcare provider. If they do bring it up, this is historically the cycle that I see in my patients is they'll bring it up, they'll come in, we do an evaluation, we're going to get started, and then they disappear again because it's just too much. And these are high functioning, like these are like a lot of them are doctors. Okay. Like a lot of them are actually like, like people that, that have experienced it and just kind of ingrained in the culture that we grew up in. And so I think, and the irony of it all is that, I always say like the South Asian community has this, concern around, the shame around talking about sex and all the things. But the reality is like prior to colonization, all the religions like Hinduism, Islam, all of them were very sex positive in the context of marriage. And so there's a lot of discussion, a lot of like artwork. I mean, you think about the Kama Sutra and some of these books that were available in pre-colonial times. And like when colonization happened, it was really a matter of like now people aren't talking about it because they brought on their sort of like Victorian philosophies around sex, and so it kind of is like put a nail in the coffin when it comes to that kind of stuff. And then we adapted that, and then that just has perpetuated in our culture, whether or not it's in the actual South Asian countries or among the immigrants that have acculturated here, we still see it. And so it's a big problem in our community, and it's a problem that's lifelong. So in the midlife, you expect that, okay, maybe you've gotten through it, and then all of a sudden you have all these hormonal changes in the vagina, and you're reliving it. And then again, you think, okay, you know what, this is just something I've dealt with. And I have patients who've dealt with it their whole life. And again, just think it's normal because that's what their mom told them. That's what their sister told them. When they did have a discussion, like right before they got married, this is what was told to them. And so I think that this is something that we all need to, really be open about discussing because it is a huge problem in our community.
Yeah. So, we mentioned a lot of tools and like tricks and tips and like throughout this webinar to kind of address both the issues that come with menopause as well as pelvic floor dysfunction. But I just wanted to kind of talk about them in one place, and maybe highlight the most important ones that you think are just the most effective for people to kind of integrate into their lives to address these issues.
I would say like bar none, like the one thing that I see that people don't get enough of is like local estrogen therapy in the vagina. So vaginal estrogen, vaginal DHEA. Every woman can take it no matter what their history is. It's not systemically absorbed. You're not going to get these huge blood levels. It's not going to cause cancer. It's not going to cause heart disease. Don't look at the boxed warning label. It is life-saving for so many people. It does restore your tissue. Genital urinary syndrome and menopause, with these changes, is a chronic progressive condition. If you do not treat it, it will continue to get worse. If you stop treating it, it will go back to the worst part of when it was. So that, along with pelvic floor therapy and dilators, I think are very critical for your genital pelvic health. People can use moisturizers and they can use lubricants all they want. Those are Band-Aids. They're a very important part of what we do. It's part of our toolbox, but you have to get local estrogen or DHEA in the vagina, on the vulva, to prevent some of these pain issues and urinary issues. And then, just thinking about your health as a whole, I think it's really important for you to think about whether or not you can find a clinician that will speak to you about the use of menopausal hormonal therapy in our population. I'm very vigilant with my South Asian patients. I tell them, we know that it's not given for primary cardiac prevention, but we know, especially women who are like a third more likely to go through earlier menopause, and they're losing that estrogen, they're having uncontrolled vasomotor symptoms, which again is a harbinger for potential early mortality, right? I just lost my mom at the age of 77 for a massive heart attack that she had that was discounted on multiple levels. And so this is very important that we discuss the fact that heart disease still kills women more than breast cancer. Hormones do not cause breast cancer. They do not. In fact, the Women's Health Initiative showed estrogen alone actually reduced the rates of breast cancer in 22 to 23% of women. There was a big disservice that was done with all of the sensationalization of the initial study from 20 years ago. And so I'm very vigilant with my South Asian patients. I have them get a calcium score in their 40s. I have them, look at their cholesterol. I have them look at their hemoglobin A1Cs. Even I'm a gynecologist, and I will do this for them if they don't have a primary care, because it's so important to get on top of this and get your lifestyle in order, exercise, diet, get the protein, get the fiber that you need, and really get some weight bearing done, because that's the other issue is osteoporosis is real. 1 in 2 women get osteoporosis. That's a weakening of your bones. Your bones are silent until they're not. When you fall, if you're a postmenopausal woman and you fall and you break a hip, you have a 30% mortality in the first year. 30%. It's not a small number. So I think this is very important. Estrogen is the best thing for your bones. It's the number 1 indication, other than hot flashes, that we give for hormonal therapy. And I think that with the latest studies that we have and the different routes that we have, most women can take menopausal hormonal therapy safe and effectively, and it can really transform their quality of life. It's not the magic bullet. You have to do the lifestyle stuff. You have to improve your diet. You have to exercise. You have to sleep. Sleep is very much a big part of our overall health. And so if you're not sleeping well, you're going to get diabetes. You're going to get heart disease. You're going to get all the things, because sleep actually impacts your metabolic function significantly. And you have to try to do some stress reduction, which I think is the biggest problem I see in our community, because women do everything and for everybody except for themselves.
Yeah. Thanks for mentioning about sleep, Dr. Rahman. I couldn't agree more. My work goes very much hand in hand with everything that Dr. Rahman will do and that she has said. So I focus more on the musculoskeletal part of the thing. If we have to think in terms of just the pelvic floor dysfunctions per se, a lot of my work is based on educating the patient. If the gynecologist has not already prescribed DHEA or topical estrogen, I will have them reach out to their doctors and talk to them and discuss if they are good candidates for it. And as Dr. Rahman said, I think everyone is a good candidate for it. Once that is in place, we are going to do a lot of manual therapy. Think of your pelvic floor muscles just like any other muscle of the body. Like if we are talking about the biceps, like if we are doing a lot of workout in the biceps, or we are holding a glass of water all day long, your biceps is going to get sore. So what do? You start rubbing it, you start massaging it. Pelvic floor muscles are very similar. So if those muscles are sitting in a very heightened tone, if they are very tight and contracted, we are going to work on it manually using different techniques. It's going to be very slow, and yes, you have to be skilled in it and trained in it specifically. There are some fascial mobs that we can use, and all of that is largely used with breathing exercises. So breathing exercises and pelvic floor therapy is going to go hand in hand. And like Dr. Rahman said before, like our what our when embryologically our tissues were such that our pelvic floor muscles and the oral muscles, they all come from the same tissues. So when we are working on your TMJ joint, or we are using the breathing, or we are making the sound with our larynx, all of that has an effect of relaxation on our pelvic floor muscles. So we use all different strategies of breathing, using sound effects, unclenching the jaw, using massage on the jaw, all of that in conjunction with the manual therapy that we are doing directly on the intravaginal muscles to relax them. And this is all for the heightened tone muscles. For the low tone muscles or the very weak muscles, we are going to work specifically using either biofeedback machine or some tools to kind of stimulate those muscles to activate again. I have some fun tools that I brought in today just to show you what it looks like. So this is a TheraWand, and TheraWand is just like a massager, or if this is your, where is my hand? Right here. If this is your vaginal muscle, then TheraWand will just actually sit here and then work on relaxing those muscles. And there are different techniques we will teach our patients to kind of use that on themselves. So that's TheraWand. And then these are the dilators. They come in 4 different sizes. There's also another set which is bigger than this. And these are for the muscles when your vaginal muscles are sitting so tight, like Dr. Rahman explained, where they are just like tight and pushing the intercourse or the penetration away. We are going to train those muscles to first relax with different methods. And when those muscles are reaching at a spot where, okay, now they are able to receive penetration, then we are going to use the progressive dilators to allow those tissues to stretch and lengthen. That's a pelvic floor per se. And then the other related to osteoporosis, weight training, progressive weight training, cannot stress enough. All the women starting their late 30s and 40s should start weight training, actually. Using starting with light weights to moderate resistance and then increasing the weights eventually will actually stimulate that bone growth formation, have more muscle development, and that's very beneficial for all of us in terms of the bone and muscle health. Resistance exercises using bands is also very beneficial. Aerobic conditioning is good. You still don't want to disregard aerobic conditioning, but um, resistance exercises in conjunction with aerobic conditioning has shown the best result in terms of musculoskeletal better health in menopausal women.
Yeah, it sounds like there's so many ways to, make that difference. Like, for a person who maybe is hearing about these things for the first time, or maybe feels some of that shame or that stigma, where do you think they should start, right? Even in just in the consideration of bringing it up to their doctor, like what are some ways that people have either brought it up to you in the past, or that you would recommend that a patient do so if this is something they want to talk about, they're just not sure how?
Dr. Rahman, is it okay if I go first? Because
Sure.
I've seen this quite often. I feel like it's very, very important to find the right doctor for you. Because being as a physical therapist, I have seen so many women, South Asian and other culture, who come in and sit there on my chair and they are crying, saying, I was dismissed by so many doctors. If you feel like your symptoms are being minimized, or if your symptoms are not being heard, go find another doctor, because there are doctors out there like Dr. Rahman who will actually advocate for you, who will actually give you the solution. So I think that's the first step, where if you don't feel heard, please go find someone else who is actually going to hear you. That's the first step.
Yeah, absolutely. And I think, some of the, especially when it comes to like, if we're talking strictly menopausal symptoms, right? Any menopausal symptoms, just, I think it's important to ask, like, even when you're making the appointment, like, does this doctor feel comfortable treating menopause? Because, at least with the latest data we had was like maybe 7% of graduating residents feel comfortable treating menopausal symptoms. And so it's important to ask, you know, at the time of the appointment, I want to make an appointment, be specific. You have to be very specific, right? Because you can't, what I see a lot of my patients do is they'll tell the front desk they're coming in for an annual. And because I normalize the conversation very easily, most patients come to me because they know I treat this. You know, then they'll tell me what's going on. But at the appointment time, they'll say, I'm here for an annual. I'm just here for a checkup. And then when I get in there, it's all sexual pain, it's all menopause or whatever. And so I think it's very important to just to be frank, even at the front desk, and say, you know what, is this doctor comfortable treating menopause? You know, I have this sexual concerns. Is this doctor comfortable treating them? Because again, there are a lot of clinicians that are not, although I think, like I said, it's changing. You know, our most recent Menopause Society meeting, as well as our most recent ISHOSH meeting, were sold out. So I think that's very indicative of that people are hungry for the information that they're not getting taught. And so they're trying to learn, but they're not going to be good at it initially, even if you learn it, right? Like even if you go to the conference and sit there and listen to it, you have to have some experience. So try to find someone. You can go to the Menopause Society website and find someone who is certified practitioner in menopause, a certified provider. You can also go to the International Society for the Study of Women's Sexual Health, ISHWSH. They have a website. I would look for someone who is a fellow in sexual medicine first. If you can't find one, then you can find someone that is a provider alone. The fellows usually have years of experience, like myself, versus someone that just becomes a member. That means they're interested. So at least that's a good sign. But, you know, obviously experience is very important when it comes to some of the stuff. And I think the issue that we have in the South Asian community is finding someone that is going to be, has cultural humility when it comes to dealing with the issues that we have in our culture. And I find that that is one of the reasons I also get sought after by South Asians, is because, you know, it's like I get it and they know I get it. So it's not like I'm going to be like, oh, you know, like what's wrong with you? You know, I mean, I'll tell you guys a story. When I was a first year resident in OBGYN, we had a lot of South Asian patients that came through. And this was a while back, before the time that we really had an understanding of some of the sexual pain concerns. You know, maybe in the last 12 years or 15 years, we have some real definitions around how to treat sexual dysfunction, other than, you know, dilators. That was like the biggest thing, only thing. And so when I was a resident, there was an attending when we went to go see a South Asian patient who was in labor, who wouldn't tolerate an exam. She had significant pelvic floor dysfunction, vaginismus, genital pelvic pain, whatever you want to call it. And, you know, that attending, to this day, she looked at me. I still think about her. She looked at me and said, you know, what's the deal with your people? They act like they've never had anything in the vagina, right? This was like post 9/11, right? So like, you know, it was very hard for me to hear anyway, but I was also an intern, so I could not even imagine at that time, you know, even the hierarchy of medicine was such that you couldn't even speak to your attending physician in any capacity. So it was jaw dropping for me to hear this, but this is how some, you know, people think. And so I think it's very important to find someone who, you know, is in a, you know, you're obviously in metropolitan cities, we're going to find a lot of people who have dealt with South Asian communities and cultures. But I think it's really important to find someone who has some cultural humility, which sometimes is a trial and error, right? Like if you can't find, and I'm not saying that all South Asians are going to be great for you, like all South Asian doctors. I've had a lot of patients come to me because they're dismissed by other South Asian doctors too, because they don't have the knowledge, and they're judgy. So you have like, you know, these balancing act situation that you have to do. And so, unfortunately, it is a trial and error. If anyone ever reaches out to me, I'll give them the people that I know. But like, you know, looking at ISHWSH as a society, it's www.isswsh.org. The International Society for the Study of Women's Sexual Health, and then the Menopause Society. And these are at least clinicians who have an active interest in bettering themselves and trying to get the knowledge they need.
Yeah.
But if you're not getting answers, go to someone else. You know, that's the bottom line.
Find a doctor, you know, or someone who's
Yeah.
willing to listen to you and put your
Mhm.
concerns first.
Yes.
I hear you. So I have this slide just about a quick recap, some false normals we already talked about. I'll read it really quickly, and then we can kind of go into our Q&A section. I know we only have a couple of minutes left, but Dr. Rahman and Shital both mentioned these things throughout the webinar. These are things that are not normal, if you are experiencing them or someone is experiencing them, think about maybe seeking medical attention. So the first is like any postmenopausal bleeding. If you have gone through menopause, that means your menses have completely stopped. So there should be no vaginal bleeding after menopause. That is not normal. That's actually a concern for cancer. So definitely go see your doctor and see what they can do for you. We already talked about urinary incontinence or fecal incontinence. This is not something that you have to live with. It's not normal. So seek out help. Pain with sexual intercourse, we talked about that a lot. Frequent UTIs, and then some other things I put on here that are also, stigmatized is like just uncontrolled anxiety or depression. Dr. Rahman mentioned that, mental health is a big thing that can change when menopause comes on. And sexual pain or some of these other things that you might be getting with pelvic floor dysfunction can also cause anxiety or depression. So it's important to know that that's not normal, and it's really important to advocate for yourself or have someone else or be the one who can advocate for someone else in your life who's going through something like this. And then we discussed hot flashes that are worsening or not getting better. We have really great treatments for these things that can really help you, including hormonal treatments. So we want to make sure we can get you to someone who can get you those hormonal treatments. But as always, be sure to consult your doctor, someone that you trust, someone that you think will actually help you. And with that, I wanted to head into our Q&A section. We kind of asked a lot of questions along the way, but I have some questions here in the chat that I can start with. And if any audience members have some questions, please feel free to drop them in the chat. Some people just messaged these to me directly. So this is open to both you, Dr. Rahman, and Shital. So one of the questions is, what kind of language or phrases should patients use when talking to their provider to advocate for menopause-related care, especially if their symptoms are being dismissed or brushed off?
Oh, what kind of language to use? I think being very direct. There's some websites that have, like symptom like there's a website called Balance. It's by Dr. Louise Newsom, and she has a great like symptom checklist that you can do. Like I feel like sometimes just bringing in the data is very helpful to bring to your clinician, right? Like these are the kind of things that I'm experiencing. Nowadays I feel like because menopause is like, for lack of a better term, so hot for, everyone's talking about it, that most clinicians that I know are, hearing about it a lot more. They're learning about it a lot more. I think just getting out there, your specific symptoms, don't suffer in silence. Sleep is a big issue for people. Weight gain is a big issue. Cognitive dysfunction, mood disorders, any of those things that you have. And sometimes it's just like you can't even quantify it, but you just know you're not feeling like yourself. And then trying to get that under control, just having a discussion. Unfortunately, our healthcare system is broken, and in a lot of big practices, you have to see patients, that 25, 30 a day in 10 minutes. And so I would be very specific. Don't do it at your annual visit. Don't do it at your annual visit when they're just going to do your PAP and leave. Do it specifically. I want to talk about menopause, and come in with your checklist of symptoms. Your last menstrual period, when was it? The quality of your period, vaginal discharge, dryness, urinary symptoms. Write them all out, and then just say, just go through them. I think especially in clinicians who have an insurance-based practice, they have limited time because they're not going to be able to see or spend as much time, and so I think it's very important to come armed with as much of your own knowledge and your own information as possible. And I think that's really important for people to get adequate care.
Yeah, I completely agree with Dr. Rahman. Specificity is it's very helpful, being direct and saying it as it is. But one thing I will say is don't go in with a diagnosis. We all can use Dr. Google these days, and oftentimes, like I have so many people who will come to me saying I have sciatica, but when I actually check them, it's not sciatica; it's something completely different. So don't there are some clinicians who will actually still use a fresh approach and will evaluate you fully, but if you're going to feed them a diagnosis, their assessment can be biased. So don't go with a diagnosis term, go with your symptoms meaning this is what I feel. I feel heaviness, I feel bloated, I feel tired, I feel moody. And mood symptoms can sometimes be very out of personal experience, can be dismissed very easily because we all are living a very high stress life right now. But I would just reiterate the same thing as Dr. Rahman said, be very specific and say it as it is.
Yeah, I think Arti, I think you had raised your hand if you're still here. If you want to ask your question or make your comment, whatever you had wanted to do.
Yeah, thank you, Prottusha, for giving me this opportunity. First of all, I would like to thank SAAPRI for conducting this wonderful session. And I was really in awe with knowledgeable information shared by Dr. Rahman and Shital. It's wonderful. Uh, I'm going through a menopause state, and my certain queries were really, I had certain questions, and they were satisfied in the session. Uh, Regarding anxiety, estrogen level, exercise, pelvic thing, you have explained beautifully, Sheetal. I never imagined, because in our childhood also teachers used to feel ashamed to talk about these terms, vagina, penis. They never used to talk. So nowadays, and there are a lot of changes. And regarding these exercise things, you have explained beautifully. My one question is, I have already gone through polypectomy. I had polyps in my uterus and it has been removed. And do I need to get my estrogen level check yearly? Though I go for yearly checkup with my gynecologist, and I have recently shifted to Chicago. So I will definitely find some doctor to examine myself. So my question is, do I need to get estrogen levels check at this stage?
Are you said you're past menses? You're done with your menstrual cycle?
I haven't achieved as yet. I'm 55-year-old
Uh-huh.
and I have heavy bleeding once a year. It's not continuous. So I'm in
Oh,
that
okay.
phase actually
The
where
period.
I'm, so
Yeah, I mean, like
estrogen,
again,
I haven't.
estrogen, we don't like again, we don't use that for any clinical diagnoses. Do we check it on occasion? Sure. It's not something we do on an annual basis. We look for those
Okay,
12 months without your cycle. If you have
okay,
polyps in the past, there is a chance that
yes.
you can get a recurrence. So that's better diagnosed with an ultrasound or a saline infused ultrasound that is done. I would only do
Mhm.
that if your bleeding became, significant again, like it was really disruptive, or if
Okay,
again you bled past menopause, you've gone 12 months without a bleed, and then all of a sudden that month 14 you bleed. So it's
mhm,
postmenopausal bleeding, right? So then that would
okay,
be evaluated. And polyps is a very, very common reason for postmenopausal bleeding. Most postmenopausal bleeding is benign, but because endometrial cancer shows up as postmenopausal bleeding, we don't not evaluate for it when you have it. So as long as you still feel like what is there anything wrong with checking your estrogen level? No. Is there anything wrong with checking your FSH level? No. It's a snapshot in time. It tells us a piece of information. It's not going to diagnose you, but
okay,
I would check, if you wanted to check it, we could check it and see what it is, and it would just be something like a piece of information that we use, but not for necessarily.
okay. Thank you. Thank you so much. Thank you.
Mhm.
I think we have time for one more question. If anyone from the audience wants to ask one live, I'll give you a chance. Otherwise, I do have some in the chat that I think there's a good one to end on. Um, okay. I think the one that I wanted to end on was just how can families, partners, or children or friends be more supportive to people who are going through menopause, to women who are going through that phase of their life? And what are things that you've seen either personally or in your professional lives?
Yeah, I do a lot of events. We just had one last week for, menopause and the M factor. And so what I see more and more is, significant others coming, right? And so I think it's really important. And there's, I can give you references for different books that I think are great. You can get mine when it comes out in 6 months. But the like obviously Dr. Mary Claire Haver's The New Menopause is great. There's Sharon Malone has a great book called Grown Woman Talk. There is, books about estrogen matters. There's books around perimenopausal transition. Heather Hirsch has a good book. So there's a lot of people who are writing the books, and there are a lot of podcasts that are available. I feel like I always tell people, if you want to support someone in your family, learn about what they're going through, right? Because everyone's affected by menopause, and if you, like I said, if you live long enough, you're going to experience it. You might have a parent going through it. You might have a sister, a spouse, or whatever. And so I think it's really important because, a lot of people end up divorced in this period of time because, again, I think I read a study recently, like up to 70% of divorced women say that their menopausal symptoms impacted their relationship. So this is not something that's happening to you in a vacuum, right? Like, there are definitely women that ease through menopause and it's not a big deal and they have no symptoms. But the reality is most people have some and they're just not identifying it. And so I think, just arming yourself with as much information as possible, getting that information. My household, people know all about my 6-year-old knows about perimenopause because, you have to talk about it and you have to destigmatize it. So I think that, like, these are things that we can do. You can listen to some podcasts. I have a podcast, Gyno Girl Presents Sex, Drugs, and Hormones. Lauren Stryker, she's from Northwestern. She has a great podcast on menopause. Kelly Casperson has a great podcast. There are a lot of people who have wonderful podcasts that you can listen to, and you can pick which topic they're talking about. You can read some books. You can go to different websites and just have a discussion. What I'm also finding in this menopausal movement is like the groups and the communities that get together. The reason women want to fly in for an event or want to do this is because there's a lot of peace in knowing that you're not suffering alone, right? And you shouldn't suffer at all. But the fact that, like, it can be very alienating at times to think, oh, I must be the only one that like hates my husband today because I'm just like so angry, or I must be the only one that can't remember anything. I must be having dementia. So some of these things can feel very alienating. And to find a community of people that are willing to discuss it, willing to have someone lead a discussion on it, whatever the case may be, I think that will bring you a lot of peace as well. But just continuing to push the narrative, educating yourself. This is a time in life that sounds dreadful when you hear all the symptoms, but it's also very wonderful. It's very freeing. Like, so many women pivot in midlife and start doing different things. I have people are starting new businesses. People are in new relationships. I had a 70-year-old that I saw just last week who was like, fix my vagina. I want to have sex with this new partner. And like, I'm like, yeah, go for it, because I'm going to give you back your 40-year-old vagina, like, and so I think it's very important to, like, try to embrace this period of time, try to educate yourself and educate the people around you.
I completely agree.
And if you're going through it, talk to your daughters about it, talk to your sisters about it, right? So it's like,
Yeah. And even your sons, for that matter. I
yes,
feel like,
absolutely.
yeah, I feel like fear is lack of knowledge. Fear is lack of knowledge. So, as
Mhm.
Dr. Rahman said, you empower yourself with knowledge. You empower your partners with knowledge. Our sons, like, when I'm in perimenopausal age and I get those mood swings, I sometimes feel so anxious and angry for no reason. Things don't happen as they always should, and I'm very vocal about, okay, this is what I'm going through because of the hormonal changes, and then apologizing for it, taking ownership of what you're going through, embracing it, and then
Right.
empowering your people with knowledge is only going to help you support. Because once we empower them with knowledge and accept where we are open to receiving help. We will need help. So receiving support, being open to receiving support, and like Dr. Rahman said, community is a big part of it. Find your village, surround yourself with amazing, beautiful women who are like-minded. You can initiate communities, support groups. All of that is going to help. And just take ownership and help yourself, because no one is going to help you.
Yeah, exactly. No one's going to save you. That's the other thing I was going to say. Like, you have to save yourself and you have to advocate for yourself. And if you're not getting the help you need, it's up to you to find someone to do that.
Yeah. Thank you for all of, the work that you put in to kind of help your patients every single day, especially patients going through menopause and pelvic floor dysfunction. And I know I am, and I know everyone here is so, so grateful to have been able to hear from you today about this topic. Sounds like some of our attendees are too. That's all I had for you today. Any kind of closing words or anything from any of the speakers?
I would love to thank you so much, SAAPRI, for inviting and giving us an opportunity to speak. Like, I'm very appreciative to share the stage with Dr. Rahman and share this knowledge with South Asian women, because I've always felt like we come from a place where we want to do so much, but there is so much lack of awareness, knowledge, and yes, we have progressed in so many ways, educationally, finding our voice, but there are still some cultural taboos we are living in, which no matter how much educated you are, you still have those limiting beliefs. So I really appreciate you taking this initiative in, kind of at least starting the first conversation on how we can break that. So thank you so
Yeah,
much for this.
absolutely. I totally agree with Shital. And I think, you guys, if there's other South Asian organizations in Chicagoland, I feel like everyone should come together. We should have a big symposium, so that we could really distribute this information among the community members so that it gets far and wide, because I think it's much needed.
Absolutely. And I will do this again, Prottusha and
Yeah.
Shobna. So count me in.
Yeah.
So thank you both.